around my patient. Okay? They allow me to solve many clinical problems in day-to-day practice. It also gives you that high-tech feel. There's nothing wrong with having that high-tech feel. Now, I will never tell you to buy a laser for the sake of marketing or just to be a high-tech dentist. That's not what it's about. But the byproduct of having a laser is your ability to be a high-tech dentist. And studies do receive a high-tech dentist just to be better than other dentists. So that's just what the studies actually come out and say. So let's look about where we use lasers in dentistry and why do we use these lasers in dentistry. Number one, they're minimally invasive. I've been speaking of minimally invasive dentistry for many years, and now the hot button is minimally invasive. You can't go past any booth in a trade show and not see the term minimally invasive. Because of the way lasers work, we get less discomfort post-operatively. So some of my colleagues might say to me, I have an electrosurgeon. I don't need a laser. With electrosurgeons, you'll see in a little bit, the zone of thermal damage is much greater. So there's a much greater area of potential damage and post-op discomfort. By using lasers, we can, in some cases, can be done just with super topical. We'll definitely have less bleeding, as you'll see in a little bit, because of who and why diodes are. And of course, as I said, patient feels you're high tech. So if lasers are so great, why the slow adoption? Well, when I do this in a live program, I tell everybody to say, think like a dentist. And the first thing someone blurts out, always for me, is cost. Yeah, I'm a dentist. I don't like to spend. But today, diode lasers are inexpensive. And if any piece of technology, any product that's not terribly can reap us tremendous clinical benefits, then it's incumbent upon us to consider to incorporate that technology into our practice. And today, the 179 deduction in the United States allows us to rapidly depreciate these products. Anything we buy, any piece of technology, you can write the whole thing off right away. So on a $5,000, $6,000 laser or $5,000 laser, you're writing the whole thing off and getting somewhere around a 40% deduction on it. So I would encourage you to speak to your accountant about the 179 deduction when it comes to any piece of technology in the office. So normally, when I do these live, we start talking about laser science. It's first thing in the morning, and the first thing people are doing is they're ready to take a snooze. They've had a bagel, they've had a coffee, and if they've had decaf, Kavanaugh is going to bore them with science. But it's the evening. And as long as you didn't drink too much today, you shouldn't be bored. But I'm going to go ahead and again touch upon science because there's some important parts of laser science that you need to know in order to use it properly. So a couple of things that are very important. First of all dental lasers, not just diodes, which we'll focus on today, but all dental lasers have delivery systems that are end cutting. Well, that's your learning curve, because what we do in our practices, we work with burrs, and burrs are end cutting and side cutting. Lasers don't cut on their side. They only cut at the end of the tip. To enhance that point further, keep in mind that the energy of a laser precedes the tip. So when you're using a tip, energy is coming out ahead of the tip, heating up that tissue and allowing that tip to create the cut. But you cannot cut sideways like a burr. You'll get a little bit of heat on the side. You may get a drop of tissue, but it will not cut like a burr on its side. What that means clinically is if I'm troughing a tooth for a crown and I stick a laser fiber straight in, I'm going to create a deep moat, but I'm not going to create width in between the margin and the free tissue. In order for me to create width, I'm going to have to angle that tip towards the tissue to create a space between the margin and the soft tissue. Lasers can also be used in contact or out of contact. And with diodes, the rule of thumb is if you want to cut, you're going to be in contact. If you want to use the energy to heal, such as treating of an aphthous ulcer or treating a herpetic lesion or desensitization, you will use the diode out of contact. When you're cutting, what you're getting is a photothermal reaction. Light is converted into heat. That light is absorbed by the target tissue, and that heat now will internally cut that tissue. And a couple of reactions can occur when we use our diode, most of which we don't really want. So we like absorption. We want laser energy to be absorbed into the target tissue. In everything we do, we would like absorption. What we don't want is reflection and scatter. Reflection and scatter will lead to damage, and we don't want that. Most of the time in dentistry, we don't want transmission of the energy. In medicine, I can tell you, many physicians will use a certain laser, and that laser energy will transmit through certain parts of tissue till it hits its target or target tissue. And the simplest thing that you could think of would be LASIK. When an eye doctor does LASIK, he uses an excimer laser. It transmits through much of the tissue until it gets to the cornea. That's where it's going. It's not burning through your eye, it's transmitting and being absorbed by the target tissue. When in the oral cavity, when diodes are absorbed by the target tissue, what we get is a cut, a superficial layer of coagulation. That means the area here will clot, so we won't have bleeding, and the heat will dissipate, but you see it quickly dissipates and doesn't go into many cell layers deep, so we don't have edema. Because this energy does not penetrate deep into the tissue, the patient will not have post-op discomfort most of the time, especially for troughing of crown and bridge, and they won't have any kind of post-op problems. For the most part, diode procedures are problem-free. Can you screw up with a diode? Yes, you can. So some complaints people will say to me is, the diode cuts too fast. I will tell you that most of the time when I'm cutting in the mouth, I'm using 1/3 to 1/4 of the maximum energy of a diode. But some dentists are inclined to jacking things up. And if you jack the power up, you can do damage. We will always see a little bit of carbonization when we use a laser, but we don't want a lot of carbonization. So let me show you an example of a mistake that someone did, and when they thought it could cut faster, but how the energy just cut too fast and caused the problem. So the diode here is cutting. You can see immediately the tissue is turning black. So I know that tissue is absorbing that energy, and there's way too much energy coming out that tip. To top it off, the dentist is going over and over and over that same tissue. Now that patient's going to have post-op discomfort here. If that patient's going to have recession up here, this is just using way too much energy and someone not understanding the proper use of a diode laser. What that dentist didn't realize, or what that dentist didn't obey, is they did not obey the rules of what I call power density. And power density is technically the amount of power of that laser at that tissue surface at that particular period of time. So what that dentist did is he delivered, or she delivered, too much power to that tissue in a given period of time. And yeah, you can cut fast. There's no question you can cut fast, but you're jumping too much power to that area. So you want the laser to cut, but we don't want to see a tremendous amount of carbonization. And once you understand the laser science, you'll be able to cut at low energy very, very safely. Now, laser is very safe, but we have to follow certain protocols so we can maximize the safety of a diode laser. Rule number one is safety glasses. The safety glasses are to be worn by patient, doctor, assistant, patient's mother, patient's grandmother, siblings, anybody in the room. Anybody in the room must wear safety glasses. And if you have multiple lasers in your practice or multiple diode lasers, you need to make sure that the appropriate glasses are being used with the appropriate laser. Do not get confused by the color of the lens. I have diode safety glasses that are pink, that are yellow, that are green, and that are blue. Do not get confused by the lens. On either the rim of the glass or on somewhere on the frame will be written what wavelength those glasses will protect you against. Diodes fall between 810 and 1064 in the wavelength. So it should say somewhere between 810 and 1064 to give you adequate protection. When you're done with the procedure, you can take your glasses and your assistant's glasses off, but the patient's glasses are the last ones to come off in that operatory. You have to realize that diode lasers have what's called a nominal hazard zone. All lasers do. And the nominal hazard zone is different for every laser and every diode. So just because you have clinician's choice diode doesn't mean the nominal hazard zone is the same as it is for the BioLase diode or the AMD diode or the Ultradent diode. The nominal hazard zone, for the most part, is the entire operatory, because most diodes, the nominal hazard zone is about 6 feet, which 6 feet in circumference kind of gets you the whole operatory for the most part. Some could be more, none of them are less. So keep in mind that diodes at a minimum are 6 feet the nominal hazard zone. That means if you're within 6 feet of the diode, and I was a perfect shot, and I took my diode fiber and I point it in the air and try to hit your eye, and if I hit your eye, I could do damage from 6 feet away. Also realize that with diode lasers, that you also have to have warning signs. With any laser, again, warning signs in your operatories and in the hallways. So warning signs have to be placed in the office. Why in the hallways? Because if mom goes prancing down the hallway looking for little Johnny and walks into the operatory without glasses, and by some chance you were making a mistake and something reflected and miraculously hit her eye, you would have a problem. The chart also has to be documented appropriately. The type of laser, the wavelength, the watts. If you're using a hard tissue laser, the amount of air, water, and laser energy. All those things, is it continuous, is it pulse? All those things need to be included in the notes. Very, very important. And these are the kind of signs that you should have floating around in your hallway and in your operatory as well. So this one and this one both should be in your hallway and in your operatory. Now, what some offices do is they will leave these up, like ours, we'll leave them up all the time. Others will take them on and off when they're not using a diode. But we use a diode so frequently that we will leave them all the time, because it's typically between us or our hygienist, somebody is using a diode all the time. Another area of confusion when it comes to diode is respiratory hazards. And it's really important to use a high speed or a surgical suction right at the site, because laser plume can be inhaled. Maybe not now, because many of us will be wearing N95 masks, but laser plume can contain vital strains of HPV virus and other organisms. So if you're treating an aphthous or you're treating a herpetic lesion, there could be viral plume in there. So you want to use high volume evacuation when you're treating a herpetic lesion, and at least a surgical suction right at the site when you're doing troughing or a fibroma removal or anything like that. Obviously, you're going to wear your masks, but you want to have suction. Plus, it's going to eliminate any odors. If you don't have suction, you are going to have odor of the surgical site. Some people will say it smells like a barbecue. Let's talk about diodes in particular. And diode energy is preferentially absorbed by pigment and hemoglobin, making them great soft tissue cutters and great soft tissue coagulators. I think you should be a staple in every office. I don't know how I would function without our diodes. We have 7 in one office and 4 in the other. The diode energy, ideally, you want to be absorbed by that target tissue, and that's what will give you your perfect cut. Now, read what I just said. Look at this first line. The energy is absorbed by pigment and hemoglobin. So here's your first lesson into being a diode expert. If you have highly pigmented tissue, maybe your patient is of Middle Eastern descent or African American descent or Italian descent, and they have pigmented tissue, you may not need a lot of energy to cut because that diode is going to likes that pigmented tissue and it's going to cut quickly. At the same time, if you have a 40-year smoker or a 20-year smoker and they have fibrotic tissue, you may need more energy to cut. And that's why when I give settings, and I'll talk settings just for relative sense, settings are for relative sense. It's not a hard truth. I will never tell someone to cut at 1 watt because it depends on the tissue. If I can cut tissue at 1 watt on somebody who smoked for 20 years, I can probably cut that tissue at 0.7 or 0.6 of a watt on someone who has pigmented tissue. So keep that in mind. Always look at your tissue to say to yourself, hey, how much energy do I need? Second rule of thumb, manufacturer presets, I don't care whose company it is, are always wrong. Why? Because what they're giving you is a safe preset that works in the lab. They can't account for tissue type. So they may say 12 at 1 watt or 1.1 watt. That's okay. You be able to do that safely. But you also might be able to do that at 0.6 or 0.7 when you have highly pigmented tissue. So make sure you keep that in mind. Diode lasers are a phenomenal tool for the practice. They're very inexpensive compared to most technology. It's what I call getting this big bang for your buck. They're also ultra portable and very versatile. The 2 most common wavelengths are the 810 and the 980. I've been working with 810s my whole life. I also have a dual wavelength diode laser in my practice now as well. That's the Ultradent Gemini that has both wavelengths in it. But for the most part, I've been using an 810 my entire life. Now, the people that love 810s love their 810s. The people that love 980s and love their 980s, I love lasers. The fact is, the 810 energy is attracted a little bit more to hemoglobin and melanin than the 980. So they'll be better coagulators. They'll be a little bit even better cutters. But the 980, if you cut with, you'll have a little bit more bleeding, but still have good cutting ability. So I think it really depends. They're all going to work. They're all going to work and work really well. So certain companies decided they were going to buck the system. 810 and 980 have been around forever. Those have been the 2 main wavelengths. So some companies said, you know what? I'm going to find a wavelength in between. I'm going to find a wavelength that in between that I can use that will work well and it'll differentiate me. Maybe not in the way it cuts, but just the fact they're not calling themselves an 810 or a 980. So BioLase has their diode at 940 in between. Sorona's got one at 940 or 930 or something like that as well. So everyone's kind of got their shtick. But at the end of the day, like I tell everybody, you close your eyes, it's a hot laser cutting soft tissue, and they're all going to work really, really well. So for me, I could never imagine a world without soft tissue lasers. I'd have to pack cord. I'll show you a cord packing case later, but I'm not a huge fan of packing cord. I'd have a hard time uncovering implants. And gingival symmetry and making proper zeniths after ortho would be difficult. Frenectomies, lingual frenectomies, impossible or really hard. And treating periodontal disease and yada, yada, yada. The list goes on and on and on. We have many options today on the market. They're all great lasers. These are all good diode lasers. Today I'm going to focus on the Blue Wave from Clinician's Choice. Clinician's Choice has a great diode laser. It's called the Blue Wave. Some things make it different. Virtually all the lasers on the market have an aiming beam. I think there's one that doesn't, but they all have an aiming beam. Why do they have an aiming beam? Because diode laser energy is invisible. You can't see it. What you can see is typically the red dot, the green dot, or in this case, the blue dot, which is a helium neon laser aiming beam that allows you to know where you're cutting. So what's different about this laser than most others is most of them have a red aiming beam, but this one has a blue aiming beam, making it somewhat easier to see in the soft tissue. We have disposable tips, and many companies have disposable tips, but they have disposable tips, and that leads to consistency. There's a battery built into the unit and a wireless foot pedal, so I can keep it charged when I'm ready to move it room to room. I just unplug it from the wall, leave the plug there, or unplug the plug from the back of the laser, leaving the plug in the wall, take the laser and the wireless foot pedal, and I go room to room. And for a diode laser, it's relatively inexpensive. And you can look it up on the Clinician's Choice website. It's sold through Henry Schein, I think. So you can look in a variety of different places, but this is a great option. When would I use a diode laser? My number one use for diode lasers is troughing for crown. Troughing for crown and bridge is the number one way I'm going to use a diode. I typically do not pack cord. Why? Because I hate it. So I just don't pack cord. So I use it for troughing for crown and bridge. It makes my life easier. What I see is what I get. I use it all the time for restorative dentistry, for access to operative dentistry to a deep box, like I'll show you in a little bit. I use it to uncover implants. I'll show you that as well. Biopsies, minor surgeries, frenectomies, gingivectomies, perio, palliative treatment. So helping to heal aptus ulcers and helping to heal herpetic lesions. And using the diode on hard tissue to reduce or eliminate class 5 sensitivity are all ways you can use a diode. Now, I just gave you a handful here, and there's 2, 4, 7 written. I gave you a few more. There's so many ways to use a diode. So some facts about a diode before we go clinical. In order for me to cut, I have to be in light contact with the soft tissue. Most diode lasers have tips that must be activated or initiated to cut, because the diode laser tip will not cut right outside the box. It'll dump a lot of heat into the soft tissue, but it's not going to cut. So what you have to do is you have to activate that tip, and I'll show you how you do that. Diode lasers can be used out of contact with an uninitiated tip to help heal aptus ulcers and herpetic lesions. And all diode lasers work well and all generate heat. So soft tissue typically has to have some anesthesia when you're cutting. Once again, when I'm cutting, I must activate a tip. When I'm not cutting, I am not activating a tip. This is the difference with the same tip on this laser or any diode, but with the same tip, what you get from the tip when you don't activate it or initiate it, you get about 50 to 60 degrees Celsius of heat. And that same tip, when it's activated, you get 100 to 800 degrees Celsius increase in heat. How do we activate the tip? Remember, I told you, diodes like pigment and hemoglobin. I'll take a piece of active film articulating paper. I will fire the laser at 0.8 of a watt into active film a few times, and then I'm able to get this high temperature, high heat temperature that'll allow me to quickly cut. How do we do that? Let me show you. What will end up is the end of the tip will look dark or black. And when you fire the laser, the tip will glow. Now you know you have an activated or initiated tip. You can use articulating paper, or you can use a wine cork. I have tons of wine corks. I don't use wine corks. I still use articulating paper. But you can use any of these if you want to initiate the fiber. Let me back up. I'm sorry, I went through it fast. So this starts automatically. Here you go. We're firing the laser tip. This is a different laser, but it's the same concept into articulating paper. And you see the glow on the tip. You see the end of the tip here will be black. And that tip is now ready to cut soft tissue. So, as I said, for us, diodes represent a very valuable tool. A tool that we use day in and day out, that our hygienists use day in and day out. A tool that we need to have plugged in and ready to go every day, first thing in the morning. So let me take you through a day in the life. And I practice like you guys. So I'm going to take you through common problems that we face this week. So first problem that we have in day-to-day dentistry. I don't care what anybody tells you, digital x-rays suck. They're okay. But digital x-rays give us so many false negatives. It's not even funny. So I look over here, just by custard. I don't really see anything going on. But I have this trusty little device from a company called AGIV. And I'll show you a few different products today, not all clinicians' choice. And this is a transilluminator. It's a couple $100. And when you shine it in between the teeth, you will see and notice problems that you may not see on a radiograph or may not see in any other way. So I'm here. I open the tooth up. Didn't look like anything on the radiograph. And I see decay. Now, one of the things I notice right away when I evaluate the situation is I have a very high soft tissue. So what's going to happen if I have very high soft tissue when I drop that box? Yeah, I'm going to run into blood. So I got to be able to tell that patient, and my line that I teach my team is inform before you perform. I'm going to say, Mrs. Smith, this is before I'll even start, that your cavity is going to extend under the gum, and I may have to use my laser to trim some of your gum tissue. And if I do, there's going to be a nominal fee involved. Most people at that point will tell me, Doc, no problem, do what you got to do. And we do. So we drop our box, and we get into go into the soup. Meaning, I'll fast forward a couple, I end up with that. I've gotten below the soft tissue. You can see the soft tissue here. And I've gotten below the soft tissue. I got two issues. I get my laser out and do what I got to do. But two, I have a high speed we have high speeds that'll be sucking this stuff up. And now in the world of COVID, the world has totally changed. So let me introduce you to something interesting. All the hand pieces in my office are NSK hand pieces. And NSK hand pieces have a unique feature, both the air-driven as well as the electrics, is they have the ability to actually have what we call a clean head system. It's a special mechanism that's designed to automatically prevent the entry of oral fluids into the handpiece, which prolongs the life of the bearings. And it's the same, whether it's the air-driven, the electrics, the slow speeds, these are in there. In the days of bacterial transmission, even though we're autoclaving and doing all these things, wouldn't it be great if we had a handpiece that didn't suck up the bacteria that's all in there? How does it work? They have a non-retraction valve that's in the unit that prevents the retraction of contaminated fluid. And in combination with the clean head system, the non-retraction valve provides an effective method to reduce possible internal contamination. So I don't get contamination at the top, and I don't get contamination at the bottom. So for those looking at hand pieces after all this, look at your NSKs, because it has something that the others don't. Well, I'm in the soup. I got to clean this up. I need a clean field to bond. How am I going to do that? I'm going to take out my blue wave. I'll take out the blue wave at very low energy, so I can clean those margins up And now we could see the base of my box. If I have any tissue tags here, all I'm going to do is take a little skinny syringe with peroxide and eliminate those tissue tags. But now I have an area that it's a playing field that's clear, that I can bond to, that I don't have to worry that I'm going to have contamination once I put my band in place. Now the goal is I got to seal the box, because if I don't seal the box, that's where I'm going to have my biggest issues. I'm going to want material to flow to all corners of the box, but I got to seal the box. Many of us use a desensitizing agent, so I want to focus on that here as well. Some people use Galuma. Let me give you two alternatives to save you a ton of money. One is a product called Hemoseal Inside. It's a desensitizer with chlorhexidine. The other is a clinician's choice product called G5. They both work really, really well. For my Canadians right now, I'm not sure if you have G5, but I know my Americans do. G5 works by coagulating the plasma proteins in the dental tubules, and you get this initial plug, which eliminates the micro movement of fluid in the tubules, which is the main cause of sensitivity. Hemoseal Inside is a similar product that has chlorhexidine in it. So how do you deal with these products? How do they work? Well, it depends on your technique. If you're a total etch or a selective etch kind of person, what you will do is you'll apply your etch first, rinse it off, then apply the desensitizer, the G5 from Clinician's Choice or the Hemoseal Inside into the dentin for 15 seconds. You'll suction with a surgical suction, leaving the area slightly moist, and then go through your adhesive process and your restorative process. So here we've placed our Hemoseal Inside, in this case was Hemoseal Inside, and we placed our adhesive, Futurion Universal from Voco, and we've placed our matrix band, our Triadent matrix band. Triadent is distributed in the United States by Ultradent, in Canada by Clinicians Research. And the goal here is we need a seal at the base of the box. This sectional matrix is imperative because this ring is made of nickel titanium, which is going to give us a little push here and a spring. I'm going to place my adhesive in place and grab that matrix with the pin tweezer, because there's a little hole there for me to grab it. And then once again, cure at the base of that box and trim the area. And here we've created the great contours done by the matrix system. You can kind of see the material disappear. Everybody wants to know what material this is when I show this case. And I have a couple. This is a product from Voco called Admira Fusion Extra. It's a single shade anterior posterior restorative. Now, for those that want a multiple shade system that's going to look great, Clinician's Choice has a phenomenal composite called Evanesce. Evanesce is a multiple shade system that looks magnificent. But you place the composite, but I got to tell you what the key is. And if you get nothing else out of this webinar, I want you to focus on this slide to the top right-hand corner. Clinician's Choice ASAP all-surface access polishers are, in my opinion, and many others, the creme de la creme of polishers on the market today. They make for direct, like composites like this, and indirect for zirconia and Emax. And these polishers will shine your restorations literally like new money. They really will make them look great. So think about those ASAP polishers to try in your practice. So we spoke about direct. What about indirect situations? When am I going to use my diodes from indirect? You know, we talk about impressions and say they're not a big deal. But in reality, they kind of are a big deal. And most people screw this step up. I'm sure no one on this webinar, but I'm telling you a lot of people will screw this step up. What's our goal with tissue control? Is to displace the tissue, move it out of the way, that the impression material or the scan can see or flow past the margin and get the necessary information, the data that's needed to fabricate a well-fitting crown. With scanners today, if you're scanning, it's even more imperative because material cannot flow past a margin. Scanners got to see the margin. So we need complete retraction. Here's some statistics from Glidewell, not mine, so you know what we're dealing with. This is what Glidewell will say about stuff coming into the lab. 50% of all impressions don't show the entire margin needed for fabrication. 70% of impressions have incomplete finish lines. Dentists retake impressions, and it's expensive to do that stuff. I didn't believe it. So I said to my lab technician, I'm going to go into the lab, into your lab, and I want to pull impressions. I don't want to look at names. He said, all right, as long as you don't look at names, it's fine. So I did. I started looking at names. I'm like, I started not looking at names, but looking at impressions. And I'm like, where have my margins gone? And I started looking here. And I started looking here, and you can see it's all different colors. Look at this one. How do you build a crown to a die like this? Undercut with the mesial, you can't see finish lines. Who knows where the margin is? Notice they're all different colors. It's all different dentists. Arbitrary by chance. Because it's not that easy to take an impression. We think it's easy. It's not that easy to do it because we have to fight two factors. Number one, we have to fight blood. And you can tell me you can control bleeding on a single prep, and I'll agree with you. 5 or 6 preps, you pull your cord, and all of a sudden one starts to bleed, and now you got a bad day. Because now that procedure became stressful. But with diodes, what you see is what you get. Our second nemesis, which is even more important when it comes to scanning, is saliva. Most impression materials can push some saliva, but scanners can't. They don't like saliva. So while diodes will control bleeding, we still may have to use a retraction paste to absorb crevicular fluid. So we have options. We have cord, electric cautery, lasers, which we're talking about today, paste gels, and maybe nothing, which I hope that wouldn't be the case. If you're a cord person, and I'm not going to convince you, Clinician's Choice makes a phenomenal cord, but more importantly, a phenomenal synergistic product that if you haven't used, is a must in your practice, called tissue goo. And tissue goo is a 25% aluminum sulfate. It's a hemostatic gel. It's gooey, it's viscous. So if you place cord, it's going to allow your cord to slide into the sulcus because it's going to create some lubrication. And it won't interfere with the set of your material. You can place it on the cord like this, or you can place it on the sulcus. And what will end up happening is the cord will actually just slide into place. So you can see here what's going on. Tissue goo is placed. And you'll see in a second how the cord will slide into place. And you see here how the cord just slips right into creating a lubricated surface. And you'll see how it just quickly slides. I don't pat cord off, and I did it here for a video to show people. What you don't see is bleeding. You see how it slipped right in? And now you've easily packed your cord. The goal is to create smooth preps. We do that with our electric handpieces. No debris. And if you're using a laser or you're packing cord, this is not the greatest picture, but you can easily see the margins. I don't think there's any question on either prep here, and you can easily see the margins. Or here. If you have margins that are retracted like that, you're assured to get impressions like this. We always use triple trays. We use the quad tray from Clinician's Choice. We've been using them for years. It's a metal-based tray, so your material will not distort, and it gives support to the sides of the impression without being cumbersome. But if I'm going to give my lab an impression that has 360-degree margins, I expect a finished crown that's going to look and be correctly. If you have, and this is a neat little problem solver from Clinician's Choice, and they do solve a lot of problems. If you have a quadrant, sometimes you all have this. We place our quad tray in place, and we can't get it to the end. There's wisdom teeth. They're in the way. With that quad tray extreme, they have an XL that'll allow us to get all the way to the back of the mouth as well. But for the most part, I'm going to trough with the blue wave. I'm going to create that trough. So these are typical preps that we have nice and smooth, as you can see. Here's our trough with our blue wave. Let me take you through a demo of this, and I'm going to talk through this. This is the blue wave. It's what it looks like. You can see the blue aiming beam on here. The blue aiming beam on your glove is different than what we would see as a red aiming beam. We have to activate or initiate the tip. We'll fire it into articulating paper a few times. Notice I'm at 0.6 of a watt. Low energy, but I've activated the tip. You see the darkness? And you'll see the glow right there telling me it's ready to cut. And now I'll go to the mouth and just show you some troughing live, real world troughing, what you'll see in the mouth as we go through this. Patient is anesthetized, but I'm only at 0.6 of a watt. Recommended setting is 1 watt or 1.1. In areas that'll bleed a little bit, that are red, they may bleed. So I'll take some tissue glue first and put it on the tissue, just because I want to kind of absorb that stuff into the tissue to prevent bleeding. What'll happen is if it starts to bleed and you continue to go through with your diode, your energy will be absorbed, the blood, and you won't cut efficiently. So I just put this on kind of as a pre-material, and as long as I don't have excessive bleeding, I'm okay. If I have excessive bleeding, it's a problem. If I have a drop of bleeding, it's not a problem. So here's a clinical tip. Hover over the soft tissue for a few seconds, a millimeter away, and then what will happen is you'll cut much easier and smoother. So I'm at 0.6 of a watt, half the recommended setting, and you'll be able to see. And if it's not cutting, then I'll raise the energy. But this is the anterior, and I don't want recession. So all I want to do is create space. If it's slow, I'll raise it. But I want to cut at low energy. And you can see it cuts pretty well. It's you can see the tissue being accumulated on the tip, and I'll wipe that off in a few seconds. I don't need a lot of energy. Notice the angle of my tip. I'm not up and down. I'm on an angle looking to create a trough. You can use cord here. That would work, but I'm a huge fan of the diode laser in these situations, especially in the anterior. I'm a huge fan here. So I'm going to go ahead and just trough the tissue. And I'm going to drop that soft tissue to where I want and bring my margin to where the soft tissue is. Those tissue tags will easily come off with hydrogen peroxide. But you can see at 0.6 of a watt, I don't need a lot of energy to do what I have to do. This is the beauty of the blue wave. You don't need a lot of energy to cut with it. It's a great adjunct to your laser arsenal. Look how quick it starts to cut right away in that soft tissue. Almost like the one we saw before, except I am not driving a ton of energy. At 0.6, I'm not driving a ton of energy. The amount of charring is minimal. So you can see how quickly it troughs these preps, and you don't see actually bleeding. And that's where the tissue glue came into play. Tissue glue, again, is a clinician's choice product. So once again, last one, we'll show you one more. And you can see again how quickly the blue wave is able to trough in the anterior, no recession, but open up that margin. You can see quickly, and I scanned this case, by the way, you can see quickly how easily these margins are scanned. So, and when you're done, you'll get impressions like this. You will get a perfect impression every single time. This is clinician's choice product. It's a product called Inflex. Very, very difficult to tear this. Gives you crystal clear margins every single time. Another problem solver from clinician's choice. Here's another problem solver that I have to talk about. You may not use this all the time, but when you need it. It's a product called Heat Wave. And Heat Wave is a customizable impression tray. We all had those patients. Wide arches, tori, can't get things to fit. Well, this is a tray that you can customize based on a few measurements that you'll take of the inter-arch width of that patient. So the kit comes with a caliper. You'll measure molar to molar and pick a tray that fits that width. You put it in 158-degree boiling water, and then that tray can become soft and customizable. So you'll be able to fit it over a torus, basically making you a custom tray. You're not going to use this tray every week. You may not use this tray every month, but when you need it, we used it 3 times in the last 3 weeks. But when you need it, you're going to have it in your arsenal. What about gingivectomies? You don't need a lot of power to do it. Why do you have to do these cases? Well, first of all, diodes are safe to use around metal. So that's not a problem. So you can go right up against the ortho bracket. Now, these will bleed a little bit because they're very hemorrhagic tissue. But I want you to focus on the buccal of 7 and the buccal of 10, 7 and 10. And I'm going to show you why you have to do these cases. And look what you see. You see white spots that have developed underneath. That's plaque that has gotten underneath that tissue. And if you just watch this and told the patient to brush better and go home, we know what happens to those patients. They come back in 3 weeks, they look the same. So be ethically aggressive and do the gingivectomy. Remove that soft tissue. Do you have to anesthetize them? Yes. Here, and here, and here, and here. Will a diode cut fast? Yes, because it's hemorrhagic tissue. It's pigmented. You don't need a lot of energy. 0.6, 0.7 of a watt. It's going to cut quickly. What about frenectomies? I say be ethically aggressive with them. You know, the maxilla, you almost always, when you have a frenum, it's almost always associated with a diastema between 8 and 9. And in the mandible, you're going to see gingival recession between 24 and 25 and overcrowding. The incisions will always break out to be the same. There'll be a diamond-shaped incision, and you don't need a lot of anesthesia. So if I have a frenum like this, I need a drop and a drop on either side of the frenum. That's it. And one little drop right here, because we have to cut the roots of the tree. So 3 tiny drops of septicane. This is a tool from Henry Schein you can buy them from. They actually sell them, they used to sell them in the veterinary division. They may sell them in the dental division now. It's called a groove director. And a groove director will pull that frenum out of the way. What do you have to be careful here with? Reflection of the diode off the highly polished surface. But it'll pull that out of the way. We do our frenectomy. Sometimes we put a suture in. Here we did. Usually we just use a product called glue stitch or skin stitch, and it comes from the Skin Stitch Corporation. And it's what it is a purple cyanoacrylate. We flow the skin stitch into the wounds, just like I did here, and that will slow down the healing. Usually I don't even put a suture. I put one here because the incision was very wide. And we flow this into the wound, which acts as a mechanical barrier to bacteria. It'll also slow the healing down. And when it slows the healing down, what will also happen is it'll prevent the early migration of that frenum back. And this will heal up here exactly where you left it. What about implant uncovery? Well, you can use them on metal, so we can put a drop of septicane here, 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 and here, uncover our implant, and take an impression the same day. Here was a scan, which is a trio scan that we scan the patient, our scanning flag, a final scan, And then our final insert 2 weeks later, you can see the soft tissue here. Perfect soft tissue, pink, stippled, absolutely no product. Here's the screw retained crown with some flowable in the center. So we use this to uncover our implants all the time. This is just a little permaflow from Ultranet that we've placed in the access cavity prior to that Teflon tape. Finally, hygiene. Uninitiated tip. Here, up until now, we've used an initiated tip. We fired that tip into articulating paper. Or with hygiene, in New York, my hygienist can't remove soft tissue. So they have to use what's called an uninitiated tip. That uninitiated tip will kill bacteria. It can be done without anesthetic. It's low energy and it works well. In states where they can remove soft tissue, you can anesthetize a little bit, raise the energy, and do what's called laser pocket therapy. Actually remove the internal granulation tissue, which the diode will have an affinity for, by going in and out of the pocket. But in New York, I can only use the diode to kill bacteria, and we use it as an adjunct to every scaling and root planing and every one of our perio patients that comes in for routine hygiene. This is a different laser, but it'll give you the concept. We're using this no anesthetic in a sewing machine motion up and down into the soft tissue. This is a demo, and believe it or not, that energy is enough to kill bacteria in the pocket. We've tried it when patients have a perio abscess, and just running that laser tip in the pocket with a perio abscess, that abscess will reduce in 24 to 48 hours. So all you have to do is have your hygienist, if they're trained, and if it's legal where you are, run it like this into the pocket. Notice the tip is not black, it's not initiated, and there's no tissue being removed. It's just using the energy to kill bacteria. 10 to 15 seconds in each pocket. That's the goal here. So what about, as we come to the conclusion, ROI? Can a laser make you money in your practice? Well, I look at return on investment 2 ways. Will I derive a profit? And will it make my life easier? If it makes my life easier, that's return on investment. Will I derive a profit? Absolutely. A low-cost laser like Clinician's Choice, the Blue Wave, that laser is low cost. You'll derive a profit because you're going to charge for gingivectomies. You're going to charge for frenectomies. Our rule of thumb is if I trough for me, just to make space, I don't charge. If I trough because the patient tissue is a mess, because they don't take care of their mouth, because they broke a tooth and they broke it subgingivally, we do charge. There's no codes for it, but we charge. So it can make me more money. It can also make my life easier. It also defines me as a laser dentist. We have people that come in and they're always asking, are we using a laser today? They kind of like the fact, they're paying for it. They like the fact we're using a laser. If you have hard tissue lasers, you could actually do a full mouth anesthesia hard tissue laser dentistry, anesthesia free. There's a big wow factor here as well. And you're going to find procedures that you may not have done. I've had people say to me, till I had my diode, I would never have attempted a frenectomy. But now frenectomies are easy. So I'll use my diodes for that. It can be an incredible adjunct to any practice. It allows you to do procedures you've never done, and maybe we'll have you attempt some new procedures. They're a great practice builder. I'll always tell a patient I'm using a laser, and they'll say to me, really, why? And I'll explain why. It's a great tool. You'll have I'm cutting your gums, and you'll have little to no post-op discomfort. Patients love it. So they feel I'm providing a higher level of care to them when I use my diode. It's a way for me to reinforce that my diode is there for me, but it's also there for them. I leave you, before I get to the question and answers, with a quote. And this quote is, my son was a college wrestler, and his college wrestling coach would say to him, if nothing changes, nothing changes. But you know what? You need to create some change in your practice. If you don't create some change in your practice, then you'll get what you always got. If you create some change in your practice, you'll create some excitement, some new things, a profit center and a way to deliver a much higher care to your patients. So what I want to do is I'm going to go now to the question and answer. I think I can get there. And I don't know what happened to my question and answer, but they kind of disappeared on me. Let's see what we got. Let's see if I can get there. And I had my question and answer the entire time. Here we go. Now I'm going to get them. Is it safe to use a diode while a patient is on nitrous? The answer is yes. Diodes are totally safe to use while patients on nitrous. The next question I could answer is it safe to use on pregnant women? And the answer is, but I wouldn't, just because you can't do anything on a pregnant person. So I would not use it on a pregnant person. What is the mechanism of diode laser in the treatment of high dental hypersensitivity? Does it work as low-level laser therapy of melting the tubules? The answer is no. The way diodes work on dental hypersensitivity is similar to how the desensitization agents work. They create a change in the tubules in the osmolarity of the fluid. By changing the osmolarity, we can decrease sensitivity. So they work in intratubular liquid or intratubular dentin in the liquid to create a change in the osmolarity. Fibrotic tissue needs low energy? No, the answer is no. The fibrotic tissue would need more energy because there'll be less blood to that tissue. So fibrous tissue, more energy, and inflamed tissue, granulation tissue, pigmented tissue will use much lower energy. Fibrotic tissue, higher energy, pigmented tissue, lower energy. Do I initiate on the blue articulating paper? The answer is yes, I do. How do I do a lingual frenectomy? You can see them online, but basically what we do is we'll anesthetize where the frenum attaches behind the centals on either side of the frenum and begin and pull that frenum tight with that groove director and just cut away at the muscle, making sure we stay away from Wharton's duct. Unfortunately, in 1 hour, I can't show everything, but I try to show you highlights of different things. And again, you can use it around metal. It's very safe. When there's no bleeding present, am I using water over the laser? Kelly, it's a great question. I'm not using water. There is an advanced technique with diodes that was no time tonight called the high fluency technique, which you can use a diode to cool the energy. And what that allows you to do is to cut without anesthetic. It's a very advanced question. You have to be really trained, but there is a way to do that. What's my nominal fee for my troughing of crown and bridge? $125 to $175 what we'll charge. Now, Steve asks, what's the benefit of laser over electrosurgery? Well, electrosurgery has a 10 times deeper layer of penetration, which will increase recession, post-op discomfort. So the lasers are minimally invasive, electrosurgery is not. We cannot use electrosurgery around metal. We cannot use electrosurgery in hygiene. So a bunch of advantages when using the Blue Wave. What kind of peroxide do I use? A regular 3% in a little skinny syringe from Ultradent with a little brush tip. So I put it in the skinny syringe from Ultradent and I kind of burnish it into the tissue and it'll remove those tissue tags very easily. What if my patient refuses a laser treatment for gum tissue? Will the patient not trust you if you proceed with restoration without needing the laser and making them think you're being charged for an unnecessary procedure? Tiffany, it's a great question. The answer is I've never had someone not refuse me because I don't give them a choice. It's about communication. You have a problem. Your cavity extends below the gum. In order for me to access that cavity and do it properly, I will need to use a laser in order to remove some gum tissue. The good news, I come back with positive. There will be a nominal fee to do the procedure. Nobody will fight you on it. They will get it. So some people say they love the G5. Love it. Continue to use it. Recommend it to your colleagues. It's a great product to use. Marco, thanks for the nice comments. What code do I charge for the nominal fee? I do not use a code. The patient pays out of pocket, but thank you for the nice comments. Or would it damage the pulp? So Mihai asked that. The answer to that is, remember that Diode energy is absorbed by pigment and hemoglobin. The direct absorption is not by tooth. If I left it on the tooth for 5 minutes, could I penetrate through, heat a tooth up, and have it penetrate into the liquid tissue, the pulp? Yes. But in moving like that, there'll be absolutely no heat rise in the tooth. Why should I switch from using cords to my laser before taking versus minimally invasive cords? So, Harney, first of all, there was a study that was published that actually showed that a diode laser was less traumatic to tissue than cord. The reality is when you place cord, you have to wait 3 or 5 minutes for that cord to work. And that's great. If you want to do that, that's fine. And usually you're packing 2 pieces of cord. Typically it takes me 30 to 45 seconds to get a result with my diode. And if you pull that and you have any kind of a bleeding, you now have to use hemostatics to try to fix it. On a single case, all right, maybe you can argue, I'll be faster. But on 4, 6, or 8 units, you have no chance to be in the game with me because I'll be done before you get started. And if you have any bleeding, you'll have a problem. So let's see what else we got. I'm getting a whole bunch of questions flying in here. Let's see what we got. Give me a second, guys. I'm trying to get all the new questions that are here. So we got one more. Miguel, thank you very much for the nice comments. I'm getting great comments here from everybody. If you have questions, feel free to email me at whitertth@aol.com. whitertth, I'll be happy. We've gone 10 minutes over. I hope you guys enjoyed. Be safe. And once again, it was a pleasure to do this for all of you tonight. Thank you.
Thank you for attending this webinar. Due to the high traffic, we are staggering access to the CE exam to improve your user experience. We will be emailing you a link to your CE exam. Please allow 2 hours to receive the link. If you do not receive the email, you can access your CE exam at any time in the future following the 2-hour period. Simply log in, click CE in Progress or My Account, click on the webinar title, and take the CE exam. Thank you, and have a nice evening.